one and all. Welcome to the series of webinars organized by Faculty of Homeopathy, Parur University. And being a Dean of the Faculty of Homeopathy, Parur University, myself, Dr. Purav Desai, heartily welcome all the audience who are taking part in this journey. Till the lockdown initiated, we have commenced this series of webinar, and till now almost more than 40 webinars have been successfully conducted by our team. This is all because of the far vision of our management of Parur University, our president Dr. Devanshu Patel sir, the director Madam Dr. Komal Patel Madam, and the four dynamic principles of all four constituent homeopathic colleges of Parur University. We successfully arrange and organize this series of webinars. Every time we are coming up with the experts of various homeopathic system, and today Rajeshwari madam is there with us for the webinar, and I request Dr. Hina madam to give introduction of hers. Over to Dr. Hina madam.
Thank you, Dr. Puro, sir, and a very warm welcome to ma'am. Dr. R. Bhuvneshwari, madam, is a research officer, scientist too, and associate professor psychiatry at National Homeopathic Research Institute in Mental Health, Kottayam. Ma'am is an ardent learner. She has done graduation and post-graduation in homeopathy, MBA in hospital management, as well as doctorate. Ma'am has a rich professional experience of about 17 years and research experience of more than 5 years and teaching experience of 12 years. She has published scientific papers in reputed journals like Indian Journal of Research in Homeopathy, Journal of Evidence Based Complementary and Alternative Medicine, American Journal of Homeopathic Medicine, International Ayush Conclave Abstract, Homeopathic Links, Journal of Homeopathy, International Journal of Community Medicine and Public Health, and Homeo Times. Ma'am has also presented several scientific papers internationally and nationally and at professional meetings too. Few to mention are First International Ayush Conference and Exhibition held at Dubai, International Ayush Conclave 2019 held at Trivandrum, LMHI Global Colloquium, and many more. She has conducted many research projects as principal investigator and reviewer. She has also delivered special lectures and seminars at many prestigious homeopathic institutes. She is the member secretary of Institutional Ethical Committee at National Homeopathic Research Institute of Mental Health, Kottayam. She is the member clinician of Institutional Ethical Committee. She was also invited by ANSS Homeopathic Medical College to be a resource person in the CME to present on the topic of child psychiatry and homeopathic management. She has prepared the Manual of Management of Medication for NABH. It is our privilege and pleasure to have ma'am with us today. Please welcome ma'am. Over to you, ma'am.
Good afternoon, everyone. It's a really great pleasure and happy to be a speaker in this webinar. Thanks for Parol University, to Dr. Purav Desai, Principal, JNHMC, and for Dr. Hina Ravel, Madam, Principal, AHMC, Dr. Hitat Mehta, Principal, RHMC, and Dr. BP Panda, Principal, PIHR. I thank you all for giving me this wonderful opportunity. And shall I start my webinar?
Yes, ma'am. Yes, ma'am. Sure.
Whether my slide is visible?
Yes, ma'am. Yes,
Yes,
ma'am.
yes. So without much delay, today we will enter into our topic. Today the topic for discussion is depression and homeopathic management. And this particular presentation I prepared for favor for students because it was informed to me that four college students will be engaged or they will be participating more in this program. So everyone knows about the depression. So it is everyone would have experienced at least once, but it is a what it is clearly it is a depression because there are different terms on it. So I start this presentation with the triad of depression, that is Aaron Beck postulated a cognitive triad of depression. Here there is a negative self percept, that is negative feeling about the self and negative about the environment, that is a tendency to experience the world as a hostile and demanding, and about the future the expectation of suffering and failure. So the triad of depression is hopelessness, helplessness, worthless, feeling guilt, and in severe cases there may be an idea to commit suicide. Whenever you come across any
Yes,
psychiatric case,
madam. Hello,
yes, yes,
madam. Slide is not moving, madam.
slide is not moving, sir. 1 second, please. Is it working?
Perfect, madam.
Ah, okay,
Yes,
I'll
yes,
present in
madam.
this manner. Okay. Yes. So whenever we see any psychiatric case, so the first thing is for the level of the student, I am saying we should know whether it is a neurotic or psychotic type. So this depression, we should first analyze whether it is a neurotic or psychotic. So for that, as I have written few points. So that is, we should in the neurotic there will not be any delusions. There is no delusions and no hallucinations. Whereas in psychosis there will be delusions and hallucination will be present. I will explain in detail in the following slide about this. What is delusion and hallucination? And coming to the neurosis, it is rarely dangerous. Whereas in psychosis, it is dangerous and we cannot predict when it will go to the danger. And in psychosis, there is bizarre attitude, and whereas in neurotic, there will be no bizarre behavior. And in neurosis, maladaptive avoidance. So avoid the stressful situation, they will be completely normal. Whereas in psychotic, it is decompensating and disintegrative. And coming to the neurosis, it is a behavior, that is impaired personal and social function. Whereas in psychosis, it is psychologically decompensating and a totally disintegration will be seen. And neurotic, there is no need of continuous medicine and hospitalization. For example, a person is having some anxiety disorder, neurotic, and he is very finding difficult or he get anxiety whenever he is using any lift. He can avoid it. It is not necessary we should admit that case and treat. So there is no need of continuous medication and hospitalization. Whereas in psychotic cases, we need medicine and hospitalization with range of psychological and somatic symptoms, with wide range of psychological anxiety cases they will be giving thousands of symptoms, and that is more towards it's like they may be saying that I'm having headache, I'm having backache, and this right arm, left arm, knee joint pain, leg pain. So repeatedly they will be saying more number of psychotic symptoms. Whereas when you come to the psychotic disease, there will be disturbance, our expressions will be in the thoughts, emotions are shattered, and there will be blunt expressions. And when coming to the orientation in time, place, and things, it will be intact in neurosis. As I said in the same example, like anxiety neurosis. So he knows that what is the time, place, and things. Whereas when coming to any psychotic disease condition, there is disorientation to place, person, events, time, etc., according to the severity and nature of that psychotic disease condition. In case of neurosis, insight is present. That is, they know that. So if I get into lift, I'm getting the complaint. Okay, he can simply avoid that condition. Or he is getting phobia when looking into some cockroach, or he is afraid of looking the fire, so he can avoid it. That means he is having some insight that he is having some disturbance by looking into it. Whereas when coming to the psychosis, there will not be insight. and any mental disorder. Usually, when coming to the homeopath, we physicians, we have our own clinical setup in private clinicians, especially only we will be involved. But actually, for any disease condition, there is a teamwork which is more effective. I am not here to say that we cannot practice alone, but this effective, it is effective when this more than, but according to the disease condition in the mental disorder, you should make of use of those people in the other field, so that you can have a better improvement in that case. So for a psychotic disorder, psychiatrist is must. In case of neurotic or anxiety disorder, clinical psychologist and psychiatrist. In case of an emotional problems, that is relationship problems like day-to-day life problem or ego clash or husband and wife conflict, counseling is must. Don't think whatever we do as a physician, we also know homeopathy, we also know how to take the case, and so we will do the counseling by ourselves. You may do to some extent, but if it is really needed, it is better to consult the counseling psychologist, and there is also a psychiatric social worker, special educator. So this teamwork, according depending upon the disease condition, and even in the case of the depression, if the patient is having some cognitive behavioral problem, psychiatric medicine or antidepressant along with the counseling they are using. So in the same way in homeopathy also, we can prescribe the medicine, and if needed, we should consult the counseling psychologist also. It is not for all the case, but depending upon the case, if it is a teamwork, that is more effective. That we should understand whenever we are treating any mental disorder. And when coming to the depression, that is a depression, that is a cause. So when cause, if you look into the cause of the disease, that before going into the depression, I should also mention most of the cases which we are seeing in the journals, in homeopathic journals, or in the diagnosis made in our OPD, we can see that it is simply written as depression. No, we should not go directly to that word, because there is a lot of standards to diagnose the case as a depression. So that is also very equal word, grief. So grief is something lesser intense than the depression. That is something leading to the pathology than severity, than it goes for the depression. Whereas in grief, it is a normal type and there is no defense mechanism. Whereas in depression, there is a defense mechanism, and self-esteem is restored in the grief, and self-esteem and self-pity is affected in depression. So no need of professional help in grief, but need professional help in the depression. So whenever you are getting any case like death of loved ones or loss of financial, this all comes to some extent under the grief. That we should understand very basically the difference between the grief and depression. Whenever there is any grief, you can analyze who is the person, the what is the attachment or nature of attachment to whom we are missing or who are dead there. So, and what is the security after the death, whether physically insecure or emotionally insecure or financially insecure. For example, he is the father of that family, then the total family will get collapse. So there the intensity is more. So we should analyze the grief there, so we can see how far it will progress to the stage of depression. And if there is a sudden death, you see all of a sudden if there is a death in the family, the entire family get collapse, or it is a many day after sick that person has died, or it is a helplessness of all the doctors. So all these things to be evaluated, then we can assess whether it's a mild, moderate or severe depression. That I will say in the following slide. So here I would like to mention that no patient will come to you directly and say that I'm having depression. And if you open a depression clinic also, you will not get any case like that. So most of the cases of depression, they come with a complaint like I want sleeping pills, or I'm having poor appetite, I'm not able to concentrate on my work. So these are all the symptoms, and you can collect these cases only from your general practice or in your general OPD. Then basing on the symptoms, then it can be referred to the your any psychiatry department. In the same way, here in the depression also, we are having two things, that is endogenous type of depression and exogenous type of depression. The endogenous is that there will be a biological factors, that is it is coming genetically, whereas in exogenous environmental factors, as I said, some death of loved ones or financial loss or something loss or some events that happened in the family, some crisis, after that getting the depression, all comes under the exogenous. It is proceeding the stress that is often present in exogenous. When coming to the endogenous, there is no such events like that. So it is coming in the hereditary, it is coming in genetic. So in this, there will be premorbid personality symptoms like cyclothymic or dysthymic. Whereas in exogenous, previously the person will be anxious or obsessive. This is a comorbid condition that comes along with the exogenous type of depression. And you can see the difference between this sleeplessness in both the type. So here in exogenous, there is some loss. So patient will be thinking. So he is a difficulty in falling asleep in the early part of the night. Whereas in endogenous, when there is a genetic in the family, basing on that, if he is getting depression, he will sleep in the beginning part, whereas he is sleeplessness in the early morning awakening. Usually patient will be complaining he is waking by 2 o'clock or 3 o'clock. That comes under the endogenous type. And in endogenous, they are more sad during morning hours, whereas in exogenous, they are more sad during the evening hours, and they feels better in the group, because when they are engaged, they will forget that some loss, or they will come out of the sad situation, and they can, if they are easily mingling, if they are sharing with others, they will feel that happiness. Whereas in endogenous type, they feels better when alone, they prefer to sit alone, they go and sit in the room, there is no social mingling with others, and they don't find happiness in sharing with others, so they will be sitting alone. In endogenous type, the psychomotor retardation, there will be suicidal tendencies and delusions are common. Whereas in exogenous type, usually psychomotor retardation and no other psychotic features. This is very clear that we are having very good scope in both the conditions, whereas in exogenous, for framing the totality of the symptoms, usually there will be some event like ailments from that particular event, that condition depression started, that we say as an exogenous. And in exogenous, once the person is relieved from that, or if he is properly intervened at the right time and he is treated, and there is no much relapse. Whereas in endogenous, when it is genetically happening, and relapse is more common. So one more thing here I would like to share is stigma. There is a social stigma that if this type of depressions, it is not necessary to go to hospitals or to consult any physician. This stigma is to be removed, and is a depression at any cost, it should be medicine should be taken. This I added for the sake of the students. So what are the areas that controls this depression, and in the that is involved in the physiological functions of our hormones that is related to the depression? We should prefrontal area, we should remember that area in the brain, in prefrontal area, that controls the emotions, concentration, attention, loss of orientation and judgment. And all these functions, these are regulated by hypothalamus. It regulates the behavior and emotions, it regulates the hunger and food intake, it regulates the sleep and wakefulness, sexual functions, and the circadian rhythm. And we should also never forget our amygdala. This amygdala plays a very important role. It's a primitive part of the brain, and it is a very important in controlling the emotions. Hippocampus, hypothalamus. So you should remember at least prefrontal area and hypothalamus for functioning, all this smooth functioning, and about the limbic system, amygdala. So these depressive episodes, there is lot of concept. Okay, so this I kept the reference at the back also. I am trying to give you the gist of so many books. So these depressive episodes are commonly seen in men after the divorce, separation, and work difficulties. But usually, depression is more common in women than in men. And in the women, these troubles in getting along with an individual, serious disease or death are the main reason for the development of depression in females. These findings point to the importance of gender sensitive psychosocial approaches in the prevention and treatment of the disorder. There is no evidence for specific genes and specific gene by environment interactions in the pathogenesis of depression. A specific genetic variation in the region of the serotonin transporter interacts with the stressful life events in the pathogenesis of depression. I will explain in detail in the next slide. And family studies have suggested that first degree relatives of affected individuals have high risk of the order, and at the same time twin studies documented that genes are largely responsible for this familial aggregation. Here being the National Institute for Mental Health, and for years together it started in 1974. So here we get lot of cases, and we can see that father psychiatry complaint, mother psychiatry complaint, and child is also psychiatry complaint, and these family type of psychiatry diseases running through the families, we are getting those type of cases. And really it is a very great opportunity to work here, and we are seeing those type of cases. And deep anti-miasmatic remedy is very helpful. And people coming here prefer homeopathic medicine, and they would like to avoid other system of medicine because it is making them to sleep all the time, and they are not able to do the routine daily activities. So basing on this single factor, this we can say that homeopathy is having a very good scope in treatment of this depression. We are having very good antimiasmatic remedy, and we have to individualize all the case basing on the totality of the symptoms, and we are expecting, and if we are work really simulacrum is found in the case, we get very good improvement in this case. So this finding that is indicates that parental behavior and other family environment are not as important in the pathogenesis of depression as previously assumed, and should not be the major focus of the treatment of depression. This particular point I want to repeat it again, because you please understand that whatever we are treating and treated in the clinic or in the OP setup, we get good number of cases where by changing the environment, the patient is improving. But really, if you want to, if you diagnose it properly, it is very clear by these recent studies that this parental behavior and other family environment are not as important in the pathogenesis, because the genetics plays a very major role in the depression. And these cytokines, stress hormones, whenever, and we have seen that 40% of genetic cause, anyone in the family is affected, 40% it goes for the genetic. And sometimes it may be due to some physical illness like cancer or brain tumor. They will be taking treatment for a long duration, and they will be feeling helpless, hopeless, and there is no use of treatment. That also turn into depression, and side effects of taking some of the medicines that also may cause. And we should never forget the personality. How comes the personality? There is a negative in all. They cannot find happiness in the life. So this type of personality development is started when there is a separated parents in the family, and that the child will lose the happiness. They will not find happiness. They always think what will happen, or if the father is alcoholic, and the mother is abused by the father, and he always worry about that what will be his future, and cannot share with others. So this type of personality is also, we should elicit what happened in their past, and whether that plays a role for the depression. So these are some of the causes, and in here they also mentioned that stress hormones and cytokines. Even though the depression is considered as a stress disorder, most subjects with depressive features have no evidence of alteration in the functions of the hypothalamo pituitary adrenal axis. What I mean to say is there will be a regular flow of this axis will be running. There is no changes at a cellular or tissue level, and these changes in the stress hormone secretion appear to be with a history of childhood trauma. Always we should try to elicit the childhood trauma, that is separated from the family or parents separated or something crisis have happened in that they are not getting proper food or the biological need. So that is all how they are brought up by their parents. That is also very important for the when you are taking the case. And clinical data suggests that cytokines may play an important role in the pathophysiology of subgroup of depressed subjects, especially those with comorbid physical conditions. And next, the most important point is role of monoamine. That is the monoamine deficiency theory. So this varies from time to time. Okay, I'm not asking you to stick on to that at present. These are all the different concepts that the causes that may lead to depression. So that is depletion of the neurotransmitters serotonin, norepinephrine, or dopamine in the central nervous system is the underlying pathophysiology of the depression. What is neurotransmitters? So neurotransmitters, they are endogenous chemicals acting as a signaling molecules that enable the neurotransmission. They are a type of chemical messenger which transmits signals across a chemical synapse. Synapse means from one neuron nerve cell to another target neuron, to a muscle cell or to a gland cell. And in neurotransmitter excess on depression, acetylcholine and corticotrophin releasing hormone. So everyone knows that, because all the medical students knows that whenever there is a stress, then obviously there will be increase in acetylcholine and increase in corticotrophin releasing hormone. That also leads to the depression. And neurotransmitters are released from synaptic vesicles in synapse into the synaptic cleft, where they are received in the neurotransmitter receptors on the target cells. So monoamines, dopamine, norepinephrine, and adrenaline, serotonin. So serotonin, these are the very important neurotransmitters in the pathophysiology of the depression. So what is synapse? So I already explained that synapse, it is a communication between two neurons formed when an axon of the presynaptic cell connects with the dendrites of a postsynaptic cell, and you see that there is a synaptic cleft. So this is where it is stored, and every actions or any signals that is transformed in the brain through these neurotransmitters. So 7 process in neurotransmitter actions. So neurotransmitters are synthesized from precursors under the influence of enzymes. They are stored in this type of vesicles, and neurotransmitter molecules that leak from the vesicles are destroyed by enzymes, and action potential cause vesicles to fuse with synapse and release of neurotransmitters. Some of it binds with autoreceptor and inhibit the subsequent neurotransmitter release, and rest of it bind to postsynaptic receptors, and these released neurotransmitters are deactivated either by reuptake or enzyme degradation. This is the main concept now in an other system of medicine in the treatment of depression that I will say later. So serotonin and dopamine. So I don't want to go deep into it. Only for completion's sake, I kept. Sir, here I would like you to concentrate that this serotonin, dopamine, these neurotransmitters, it is a depletion of these is the reason or that plays an important role in the pathophysiology of the depression. And I would also like to point out that this serotonin, it's a large amount of serotonin, 90% is found in enterochromatin cells of GI tract. So small amount is found in the platelets and nervous system. So this may be the reason for some time. So why we are happiness? Whenever serotonin is in normal or it is in excess, we will feel happy. And sometimes you see it also control. I already said that this hypothalamus is also controlling the intake of the food. So this is serotonin is also found in excess or secreted in GI tract also. So when it is normal, we feel happy. That is why you see maybe the reason that when you have a good lunch or any feast, any dinner with your friends, with your family members, when you're taking nutritious food in a happy mood, then obviously when your serotonin increase in your body, you will be feeling that happiness. So it may be the reason that GIT tract is also involved in that serotonin, and that is a secretion. It is 90% is found this serotonin in the GIT tract. And the dopamine, it is also another important hormone that plays an important role in the pathophysiology of the depression. So this is a dopamine is the inhibitory hormone secreted by hypothalamus, and it is plays an important role in pathophysiology of the depression. So this is a serotonin theory of depression. This is a presynaptic and postsynaptic in the synapses. So this is secreted by here tryptophan, and this is a pathology. So we have already discussed that for easy understanding. I kept that. And synaptic transmission. So one of the most important advance in neuroscience was the pioneering work of Otto Loewi that nerves communicate with one another is through chemical transmission. A well-known fact is that pre and post synaptic events are highly regulated and are the basis for plasticity and learning within the central nervous system. So neuroplasticity, that is an important concept nowadays. Everyone is talking in this field that that is a degeneration, and there is a this involves in all the process like learning also. So learning, once we have already learned in our younger age, and if you feel that it is a faulty learning, then you can unlearn it and you can go for relearning. That is, regeneration is possible. That is neogenesis. So plasticity is possible in the brain. It is not that whatever we have learned previously, it will remain, our brain will remember that. If you give instruction to your brain that what the habit, suppose if you are in the habit of daily waking up at 8 o'clock, you think that that is right. But once if you got an insight, you should wake up at least by 6 o'clock when there is rising in the sun. You can create that habit because brain has the function of this plasticity. So for create any habit, for example, I will say you every day by 6 o'clock you think that you should get up, then you follow this for 21 days. Definitely once you make it as an habit, then it will be very easy. What is the purpose of creating any habit is that is it is an effortless. So anything you make it your habit, you can do it very easily and you don't feel any frustration, and you can finish that work without any much problem in that. So you do anything or you make it as a habit. That is, if I want to get up at 6 o'clock, you make it as a habit, so it will be an effortless, so it will be easy for you. You don't feel like, oh, my mother was asking me to get up at daily at 6 o'clock, I don't feel like that. If you decide that you can do it, and if you're fixing that schedule, and if you're planning for it, and you are scheduling and following it for 21 days to your maximum or to the 48 days, definitely your brain will learn, and your habit of getting 8 o'clock will slowly vanish, and you can make yourself by creating your habit. So these are all the neuroplasticity of the brain. Brain will learn if it is a, if you want to make use of it, and if you are bringing that insight, you can regenerate it. So synthesis of the neurotransmitters, their storage in secretory vesicles, and their regulated release into the synaptic cleft between the pre and post-synaptic neuroses are the important steps for the chemical transmission, but also the ending of neurotransmitter action and the initiation of the field cellular response via different steps in the signal transduction cascade. Altered function in one or more steps of these chemical transmitters may be an important mechanism underlying the depression. So it is now well established that these mechanisms are targets of antidepressant action. So you can see in this diagram that what is a synapse? Synapse is when two cells communicate through chemical signals. In healthy women, the transmission of serotonin remains more or less balanced. In menopausal women, as estrogen levels fluctuate, you can see the serotonin levels often drop, which may produce depression. So you can see in the left hand side, there is a normal serotonin level, and in the right hand side, low serotonin level, that is an impaired synaptic activity. And here the same in the dopamine also. Then the next is the neuroplasticity and its development. So what is neuroplasticity? It refers to changes in the neural pathways. As I said before, you can create, and that is a new one can be done by giving instruction, and synapse due to changes in behavior, environment, and neural process, as well as changes resulting from bodily injury. I don't think that you can create this. It is by habit, by giving instructions to the brain, by making cognitive function that is functioning. That initiation will, that we have to schedule it. It is. I'm not saying that it will happen the next day. So this is big. It is possible. It is possible. Positive thinking is possible. You can anything. You can whatever you have learned wrongly. You can unlearn it, and you can learn the new one. So it describes this neuroplasticity describes how experiences reorganize the neural pathways in the brain. So long lasting functional changes in the brain occur when we learn new things or memorize the new information. These changes in the neural connections are called neuroplasticity. So this falsifies the old concept the brain is a physiologically static organ. No, brain is, as per this theory, the brain is it's not a static. So after birth, the information in the brain from sensory organs of a newborn must be stored in the brain, processed, and this nerve cell must make connections with one another. So don't want to go in deep. So that is within 2 years, that 15,000 synapses will be there. So as we get old, these synapses that will be through a process called synaptic pruning, which eliminates the weaker synaptic contacts while stronger connections are kept and strengthened. That means if you want to keep up your habit of getting at 6 o'clock, you only should try for it. If you are missing it, or if you are denying it, or one day you skip it, then slowly that synaptic contact will go, that becomes weaker, then it vanishes. Hope you understood what is neuroplasticity and its development. So with that, I would like to say that at least you remember what are all the things like cytokines, stress. Cytokines plays an important role. Neurotransmitter, that is serotonin, norepinephrine, and dopamine. Then neuroplasticity. So this I would like to say this is plays an important role in the pathophysiology of the depression. So these symptoms. So these are the symptoms: depressed mood and hedonia. And hedonia means diminished interest or pleasure. So as I said before, no case will come only with mental symptoms. So there will be lot many physical symptoms like fatigue or loss of energy, weight loss, insomnia or hypersomnia, psychomotor agitation or retardation, constipation, reduced sexual desire, cognitive symptoms, thoughts of worthlessness or guilt, impaired thinking or concentration or indecisiveness, thoughts of death or suicide. So whenever you are diagnosing any case, you follow ICD-10 or DSM-5, and in ICD-10, mild, moderate, severe depression without psychotic symptoms. I already said you what is that psychotic and what is the non-psychotic symptoms. So based on that, this ICD-10 criteria, whenever any case comes, you can give the intensity of your disease: mild, moderate, severe, with psychotic and without psychotic, and unspecified. And in DSM-5, same thing: disruptive mood, that is a single episode, recurrent episode, dysthymia, or premenstrual, or induced medication induced, or due to another medical condition, or unspecified. So before going into deep, what is the depression? We should know few things like mental status examination is important. So for that purpose, I have given small meaning for what is affect and mood. What is affect? Affect is emotional state at any particular time. So now I am talking to you. Whether at this moment I am happy or sad, that is at moment, at particular time when you are taking the case. What is the thing? That is the affect. Mood is prevailing emotional state over a longer period of the time. So people mood does vary according to events. That is, it is reactive, and some welcome events like you were passing the exam or getting promotion, you will be happy. And if it is untoward, then suddenly you there any bereavement or failure, you feel sad. So this is the mood. That is, there is some after that particular incident or particular happenings or particular event, if you react to that, that comes into the mood. So our mood is fairly constant, equable, and euthymic. That is a normal state. When dysthymia, it is an abnormality of the mood, that is a persistent depressive. That is, if the depression is persistent for 2 years, continuously it is persistent, we say that it is a persistent depressive. And hedonia, it is usually enjoyable activities are no longer of interest or enjoyment, then we use the terminology anhedonia. Abnormal thoughts. In depression, we get preoccupied with some thoughts. So I kept this only for your understanding. So what is preoccupied means? What is it is with certain thoughts, we'll be always thinking of that. For example, if you're thinking tomorrow there is a driving test, you'll in the day before you'll be thinking of that. You will think of your steering, your brake, and accelerator like that. So preoccupied with that thought. And obsession. Obsession means some thoughts may enter a person's mind unbidden, that is arising without the conscious effort. So though the person knows that it is irrational or it is a nonsense to think, but it keeps on recurring, it comes to his mind, he cannot resist it, then we say it is an obsession. So in depression also, we are having this preoccupied and obsession thoughts. What is delusion? Delusion, it is a belief that it manifestly untrue, is not culturally accepted, and holds it with an intensity that cannot be argued against. Okay, in major psychiatric illness, you get a delusion of poverty. That means have no money when they are in very fat, very comfortably off. In severe depression, so you please note it down. It will not happen in all cases of the depression, like mild and moderate. When this depression increasing in the intensity, this delusion of poverty. Actually, he will be a warning. He may be a millionaire, but he is having a belief that he is a poverty. So that is his belief. Actually, it is not like that. And hypochondriacal delusions. That is, they have terminal cancer. However, you assure you that he is not having disease, but he will be keep on believing that he is having a disease. This also happens in severely depressed mode. Then infestation, delusion. Here in depression delusions, they feel that they are infested with insects after an illicit sexual relation. Then they will have nihilistic delusions. That means I have no head or I have no heart, and there will be a delusion of guilt, like psychotic depression. Someone might incorrectly believe that they have murdered. They feel guilt. They feel they think that this whole pandemic is because of me. So that is a delusion of guilt will be there. Then hallucination in very severe depression, and there will be an auditory hallucination. Hallucination means a sensory perception where there is no stimulus. So without stimuli, there will be a sensory perception. So whenever there is any case in at physical level, we go for blood investigations, X-rays, USG like that. When coming to the psychiatry, there are 4 methods for assessment. One is psychiatric history. The history we are getting from our patient, and we will go for mental status examination of all the case. And you should never forget to go for physical examination and the relevant medical, social, and psychological investigations. Subtypes, there are different subtypes. Already it is 344, so let me give a gist of it. That is a melancholic type, and atypical depression, and catatonic type. Catatonic and postpartum, that comes within 4 weeks of childbirth officially, and seasonally, usually it occurs in winter season. And psychotic, psychosis exclusively in context of major depression. So it will never come in mild or moderate. Don't confuse with other type of psychiatric disorder. These psychotic symptoms will not present in all the depression. As I said before, in ICD-10 and DSM-5 there is a subclass, that is depression with psychotic and without psychotic. So it in few cases these psychotic symptoms like delusions, hallucinations, and usually it will be found in major depressive disorders. And endogenous type, I already explained what is endogenous. Endogenous is a genetic one. There is no external precipitants, and minor depression has a fewer symptoms and a less duration, that is less than 2 weeks, whereas major depression will be duration will be more than 2 weeks. And the chronic versus acute, this everyone knows that acute is 6 months, subacute 6 to 24, chronic is more than 2 years. And longer the duration, the worse will be the prognosis. And premenstrual, it usually occur 1 week prior to the menses and resolve within 1 to 2 days of menses. And in bipolar also it occurs. Like depressive symptoms used in this is, it will be atypical symptoms, and history of mania, hypomania, or mixed episode will be found. So how the daily activities, what are the activities or symptoms, how do we elicit it? That is the domains of dysfunction, their achievement, their interpersonal and intrapersonal. We should analyze these things, and you see that the productivity will be less. So they will be always sitting in one place, they will not communicate, and they will not go for their school performance will be very less, and they will not mingle with any family members or social members, and they have very minimum number of friends, and they will not have any leisure spending. They will not go to any cinemas or any theaters or any club anywhere outside, and they will not take part in any religious activities. And there will be intrapsychic, intrapersonal, they will feel even without having the complaints, your USG and all other symptoms will say you are perfectly all right, but still the patient will say that he is having some complaints. That is a intrapsychic pain will be there, and impaired self-worth and discouragement regarding future. So the important thing in any psychiatric condition is you see the duration of the symptoms. So how long it lasts during a day or even several days in a week, and usually quantified. Example, I am tired for almost the entire day, and how frequently, how often in a day per week or days per month I am tired most days of the week. Intensity, subjective experience of how arise a symptom. So being tired like that is very difficult for me, not getting my regular duties. So you can see that we are having a 100-bedded hospital here, 50 for the department of medicine and 50 for the department of psychiatry. It is very difficult to handle this type of very severe depression. They will be simply sitting in the place, it is very difficult. They will not take bath. So you can see that the duration, when a frequency and intensity, when it is severe and major, it is very difficult to handle that. I will say that in the MSc. So MSc is in any case of psychiatric condition, you should look for mental status examination. At the time of examination, what is the look and appearance? Usually in case of the depression, their hygiene, that is a very poor hygiene. They appear untidy and they feel bad about themselves, and there is no motivation. They will not comb their hair, they will not wash their clothes, and it looks dirty, and women will be stopped putting makeup and men will be stopped shaving. This is how that ugly look. They sit dejectedly, gazing down at floor. They do not make eye contact with you. They fail to smile in response to greetings and jokes. And preoccupied, as I have said before, they are having obsessive and preoccupied thoughts, and they will be in their own world and serious in manner, and their movements will be minimal, that is psychomotor retardation and slowdown, because they are not at all involving. They don't want to come out of that sadness, and during the interview they prepare to sit alone brooding in a chair or lying in a bed for hours during the day. Even if you spend 1 hour with them, you cannot elicit even you cannot get any 2 to 3 symptoms from them. It is very difficult, and they will be sometimes fidgety, slow, restless, and tense. It is a lot of, we should put lot of time and effort in collecting a symptoms from them. Sometimes they will be resistant. Even after 2 hours, they may not be opening their mouth, and it will be very difficult and you will not get even a single symptom from them. This also happens. And the speech, it may be too much or little, too loud or quiet, it may be too fast or slow, a minimal, monosyllables, even mute sometimes. As I said, they may not talk, or sometimes if they're talking, they'll be talking continuously, but will not give you any characteristic symptoms. And there will not be any spontaneity and variety, and facial expression is sadness and anxiety. So this is an the depression phase expression, omega sign, and Veragod's faults. So, what is the mood and affect in this case? They are sadness, tearfulness, and don't forget that irritability. It is a very important symptom in depression, and mostly we made sometimes diagnosis wrongly also. So, irritability is a very great symptom that comes along with the depression. And thought process is the patient dwelling on a topic to what extent. So preoccupation versus rumination. So different topics come to mind versus perseveration. They response to the first stimuli, then after that they will not be getting response. So they will be simply sitting to that. And thought process. So when asked about thoughts and preoccupation, describe a catalog of worries about the money, close relationship, health of themselves or others. So rarely they say no thoughts, because their thoughts have slowed down so much. So they will be simply sitting, so nothing in their mind. So they are preoccupied only that they think their future is gone. So they will be always feeling only negativeness. So they will not share with you. They don't feel like talking to you, and they will be always sitting in one place. So these are type of things you get in the severe depression. So think little of themselves, their abilities, of their achievements. So usually it will be brought by the family members only, not by the patient. Or if at all they are coming, they will give you some other symptoms like they are having sleeplessness, or they are having the poor appetite, or lack of interest, or they are not able to read it properly, lack of concentration. So this is how they will be giving you the symptoms. So it is the duty of you to diagnose it. As I said before, it will be found more frequently among us, but we ourselves may be sometimes like that, but we may not know that they are in the depression. And examine carefully the severity of continuous cognitions of guilt. They feel that guilt, worthlessness, helplessness, and distinction between a typical depressive cognition and delusion can be difficult, but it is imperative. Experience, as I said, hallucination will be there, and insight and judgment. Remember to ask about disassociative experience, that is losing time, derealization, and depersonalization. There will be a poor judgment, often as a social manifestations. They adversely influencing behavior toward others, or prompting sudden major relationship decisions. So that judgment will be very poor, and they don't feel that they are having the disease condition. And cognition and orientation, there is a gross disturbance here, suggest moderate to high severity of depression or pre-existing cognitive disturbance. So cognitive testing is often problematic. So it is difficult because they will be not oriented. So concentration difficult, although grossly oriented to time, place, and person. Test of attention, such as serial sevens and the months of years reversed, and they are poorly performed. So, the other system of medicines, they said that CBT, cognitive behavior therapy, along with antidepressants, is giving a very good result. So, cognitive behavior therapy, you can advise to the patient along with your similar homeopathic medicine also. And in memory, there will be short-term memory defect, problems with registration and concentration rather than recall. So depression in the elderly may mimic dementia, but they call it as pseudo dementia, because they are not doing, they are not concentrating, they are not looking around. So obviously their memory will not, nothing will be registered in the mind. That may be the reason for the loss of memory in these type of cases. So what precipitated the depression? So adverse life events such as exam failure, bereavement, job loss may precede the onset of the symptom. But in most of the cases, you see that onset of depression is so gradual that it is difficult for the depressed individual to date exactly when the illness is started. So depression has become a way of life to the depressed person. Only outsiders can see the illness. I would like to note this point, because They will not come and say you that I'm having depression. It is the family members. So most of the time this is a family doctors. So one doctor will be there. Previously it was a system, but now there is a lot of online consultation and other thing. But previously it is a tradition that in our India, like there will be one doctor will be there, and all the family members will be consulting him. And if he says or refer the case to some other any pulmonologist or some, then he can very easily identify. So only like that it can be identified, and no individual will say that I'm having a depression. Fatigue as the main problem. That will be the first problem. They will not say that they are having project here on based on the depression, and in most of the cases we have seen that there is that is genetic cause. It is the chemical transmitters, that is the neurotransmitters. Okay, so that is the your medicine which you are selecting for your patient should act at that level. That is the purpose of my presentation today. When you are giving medicine, it is not that simply you change the environment or you give some medicine superficially. No. So whatever you treat that type, if you get the response, that is only when there is an exogenous. So when there is some life events, so after that a particular thing you get that comes under exogenous, and there will not be relapse. So that is only an exogenous type. But you see within hospitals like this, mental health centers, where you get more number of cases of endogenous, and it is really challenging, where you should go for the deep anti-miasmatic remedy. So where there you will not get any precipitating factors. It is a genetic. 40% they say that depression is genetic. So where we have a very good scope by our anti-miasmatic remedy. Secondary depression. So depression is diagnosed in 50% of the patient with illness such as multiple sclerosis, pancreatic cancer, and increased rate of depression are also observed among highly prevalent illness such as in stroke and MI. So sleep. So you ask whenever there is a sleeplessness, it is a this depression. It is a vast topic, and it is not possible to cover within a 1 hour. So don't expect me to say all the points. So I have given you an idea. So what will be the depression? So anything I have seen. We are having a clinical club discussion of this type of diseases in among with our students, and last week we discussed all the published topics on the depression, and we found that there is no characteristic symptom of depression to diagnose as per the ICD-10 or DSM-5. There is only few symptoms like sleeplessness, sadness, and appetite loss. So it is not a real case of depression, but labeled as a depression, and we are claiming for the improvement. So such things should not happen. You should go for your ICD-10 and DSM-5, and you properly diagnose whether it is a depression or it is a grief, it is an exogenous type or endogenous type. Because it is important. It is important when you are publishing in your scientific paper, it should be properly diagnosed, and if you're really getting improvement, that should be really documented and published. So this sleep in depression itself is a very big topic, and whenever you treat any case of depression, we have treated many cases, and we found that sleep is the crying. Person who is coming with the crying, they stop crying. That is the first symptom we are getting improvement. Then comes the other symptoms gradually improving. So sleep is very important. So when you are taking a sleep history from the patient, you make it very clear what is a initial insomnia, middle insomnia, or terminal insomnia, or hypersomnia. And if there is a suicide, you should be very careful. You cannot simply do like that. And here also we have seen some cases. So they come with the suicidal ideation. You cannot control them. Even morning also they will be keeping quiet, and they will be repeatedly saying that. And such cases also committed in spite of our routine observation. A very severe case of depression, you cannot avoid it. So it is highly impossible to treat at the clinical setup. So if the patient is having severe suicide, that should be immediately referred, and it should be monitored 24 hours, and care should be taken RMET in higher potency, it is giving a very good result, but still you have to take care and you should monitor, you should observe the case to save them. And increased or decreased appetite or weight. So there may be increased or decreased appetite in the depression and irritability. So irritability will be found in both depression and mania, but you see that in case of the depression, that irritability is most towards the loved ones and people who live in close proximity. So we cannot say indifferent to the loved ones. Don't take that is a characteristic symptom of the depression. Whereas in coming to the mania, that is expressed with less selectivity. So that is co-workers, strangers receive the wrath of the irritability. As a time spent together, family is more likely to receive the wrath. So this is a basic difference between the irritability in the depression and mania. So in depression, the anger will be expressed to the loved ones. So this is a pattern of disturbance in appetite, weight and sleep, and usually all the three will be reduced. That is a classical. You see the second one, all the appetite, weight, sleep all are reduced. That is a classical depression and melancholic depression, and there is an atypical pattern. There all appetite, weight, sleep all will be increased. Okay, so there you should suggest it is a bipolar one or it is a seasonal one. And if the appetite is reduced and weight is increased and sleep may be increased or decreased, but appetite is reduced, you rule out any organic pathology. And if the appetite is increased, weight is increased, but sleep is reduced, in that case you see that there is any organic pathology in that type of cases. So thyroid is one of the condition you should rule out along with that. And usual comorbid condition that comes along with the anxiety, depression is the anxious and OCD. That both the disease usually comes as a comorbid along with the depression. So depression rating scale, Beck depression scale is there, Hamilton depression scale is there. This is the two scales used by most of the physicians. The basic difference between Beck and Hamilton is done by clinician and Beck is done by self. So learning point, so depression illness affects 10 to 18% of the adult population. If largely untreated, patients do not seek medical help and only family doctor recognize, and depressive illness is treatable. Always ask depressed patients about suicidal ideation and suicidal plans. So key point, first cognitive function that is affected is judgment. So that is they think they are not having a disease. So that is a cognitive function is affected there. So they tend to blame themselves and do attribute illness to the illness. So slow onset of symptoms over time, can't judge when it become disabling symptoms. So collateral information is usually very helpful to determine what may be reality and what is depressive negativity. Collateral information is that is information other than the patient, usually by the if it is married by the wife or from the mother, father, siblings, friends, if they are in the hostel, so they will give you the correct information. This helps to determine the onset and also improvement in the symptoms. So management in acute bipolar, this I kept for only for the sake of students because they should know what is the current treatment given by other system of medicine also. So in acute bipolar, they use mood stabilizer and they also use monoamine oxidase inhibitor. And as I said before, this serotonin neurotransmitters. So this has replaced now antidepressant. They say it has SSRIs. So depression selective serotonin reuptake inhibitors. This is they are saying it is less side effect and it has replaced most of the antidepressant. And another agent is venlafaxine that inhibits the reuptake of norepinephrine, cognitive behavior therapy, and ECT in case of risk of suicide, and there is a stuporous condition of the patient and with the psychotic or when antidepressants are not ineffective. Then we come to the homeopathic remedies. So as I said before, purely it is 40% of the cases it is genetic. So I say that only anti-miasmatic is a very good remedy, individualization and totality of the symptoms. As I has already said, childhood trauma, elicit that case taking case taking is very important, and you always look into the pre-morbid. Rule out all the common symptoms and look for the characteristic symptoms like desires, thermal conditions, and pre-morbid symptoms. Why before getting these type of diseases and this family. So RMET, it is found to be very useful. Staphysagria if they are introverted, and natriumur, it is very useful in higher potencies. Most of the cases I have given tenum, that is in genetic level. I used to give natriumur tenum monthly once also, so it is more effective. And staphysagria also in higher potencies. We will look into few symptoms. I will rush it off and I will finish in time. Already it is 4:05. Please excuse me. I will finish it in 10 minutes. So RM metallicum. So main idea essential to RMT is the self. Okay, that is a willpower is last. In that cases, they think RM is depression and loathing of life. Ultimately, this person does not want to live. So will is last there. They are very closed people. They feel themselves quite separate from the world. So display despondency, dissatisfaction with life in general, especially regarding social and interpersonal relationship. So thoughts turn constantly to suicide, indicated many cases RMT10. It has helped me a lot in many number of cases. We can prevent that suicide. So it will be an impulsive. You have to take care immediately. You cannot give low potency 30, 200, and you cannot wait, because next visit tomorrow you will ask the patient to come. We don't know whether he is there or not. So it should be fully monitored, and it should be quickly taken care. It's an emergency situation. In my experience, so I'm not generalizing, and most of my cases I've used RMT Tenam, and it really helped me in many cases. And Ignatia Amara, it is a person become depressed after shock, grief, disappointment, bad news, reserve. So these all they comes under the exogenous type. So that is after that precipitating. But actually in these type of cases, it will be maybe mild or moderate type, and that case will give you there's ailments from. So that type of cases we get in clinical setup, and without IP admission, you can treat those cases. But when there is a severe depression and there is an idea of suicide, and if there is a psychotic symptoms or like delusions of guilt, and you see that they will not take bath, they will feel very guilty, and some hypochondriac delusions. So this type of cases sometimes it need IP admission, and it should be treated in IP setup. If there is a suicide, it should be fully monitored. So natriumur, it is again a wonderful drug in homeopathic metromedica. It is most of the cases we get very good result, and I prescribe in higher potency. I start with 6C also in some cases based on the protocol. In few cases that also works, but repeated treatment and for the immediate effect, natriumur tenum monthly one dose, it is giving a very good result. Acid pass, pulsatilla, sepia, Staphysagria. Most of the cases, this Staphysagria works, and Lacaninum, Sorinum, and in synthesis repertory, and few of the rubrics I have taken, but it is very scattered, and now everyone knows different types of repertories are there in any language, so it is very easy for you. But my only advice is that you look into the individualization and you go for the deep anti-miasmatic remedy. So I kept here for 4 cases, and this is a case, age 23. This is ailments from mortification. So based on this, weeping tendency was there, reduced sleep, and reduced talking, not interested in activities. Staphysagria was given, and the patient improved. So this is again exogenous, that is after grief. And another case, age 47. This is ailments from after the death of the mother. I prescribed causticum 200, then 1 I got very good result by giving causticum 1 That case is still under my follow-up in 2021 also. He is a cook, and his mother died. He is not married, and and he was having that all the type of symptoms like sleeplessness, lack of confidence and energy. but after taking our medicine, he has improved a lot. And recently, he got a government job, security, and it is a good news. And he also said me one good news: he is going to marry one lady in the age of, you please remember, it is in the age of 40, 48. He is willing to marry. So this credit goes to the homeopathy.
मैडम हाँ बैठे बैठे
Next is a case of a 65, and here ailments from misbehavior of officers towards him, and natramur is the drug given, and it has reacted well with natramur 1 now. This is another case, age 37, and this case is after leukemia in 2011, and the constitutional remedy we have given pulsatilla, and the patient has improved. I am also looking into infertility case, so I find more number of cases that is in infertility OP also, because they are not having child, they are inability to conceive, and that case goes to the depression. And I have seen more number of cases with menstrual complaints, and there also this pulsatilla, sepia, natramur, it acts the best, and that even in the higher potency. These are all the references, and thank you all for all your patient hearing.
Thank you, madam, for a nice presentation. Now, I would like to request my colleague, Dr. Siddharth Mehta sir, to give concluding remarks. Over to Siddharth sir.
Thank you, Panda sir. Depression and its homeopathic management. The topic itself is a very important topic for any homeopath, how to tackle the depression, because majority are coming with the lot of stress right now. So it's a very important topic. Madam started with the basic difference between neurosis and psychosis. And the differentiation for the neurosis, that is delusion which has been not presenting in case of the neurosis, which is presenting in case of the psychosis. That is rarely dangerous. Neurosis, psychosis, which is dangerous sign. No bizarre behavior which has been observing in case of the neurosis, which has been observing in case of the psychosis as well. Insight which has been presenting in case of the neurosis, which is not there in case of psychosis. Then madam started with the how to approach the homeopaths, that is the mental ability. If patient is coming with the psychotic disorders, so there is need of the psychiatric to assist the case for, as a homeopath. If patient is coming with the neurotic behavior or neurosis, then there is need of the clinical psychologist along with the psychiatric, which is needed. When patient is facing the emotional problems, and we need the counseling with the help of the psychiatric as well. And madam started with the differentiate the endogenous and exogenous. Endogenous is a psychotic problems, and exogenous is a neurotic problems. Biological factor which is presenting in case of the endogenous, which is in case of the exogenous, that is the environmental factor which is very essential. Feels better in alone in case of the endogenous, and patient is having the better in group in case of the exogenous. So nicely correlation of the pathophysiology, that is the nervous system, limbic system, and the function of the hypothalamus and hippocampus, and the depression which has been commonly are in episodes, which has been very common in men nowadays because of the divorce or separation or working difficulty. So nicely correlate with the pathophysiology, that is stress hormones, cytokines, depression, and role of monoamines. The relief of the neurotransmitter, that is the neurotransmitter are the endogenous chemicals, the junction of the two neurons, which is known as the synapse, and the dendrites, which has been help of the neurotransmitter with the conduction of the nerve cells, synaptic transmission, which is very essential, synthesis of the neurotransmitter, then storage in secretory vesicles, depression which has been caused by the serotonin, and fluctuation of the neuroplasticity, which is very important topic for the nervous system. Whenever there is changes in the neural pathway, which has been resulting because of the synapse due to changes in the behavior, environmental factor, or either neural processes. So nerve cells which makes the connection with the one another and transmitting the impulse to the surrounding, to the brain as well. So symptoms of then madam started with the clinical features, that is depressed mood, and anhedonia, that is diminished interest, or cognitive symptoms, that is thoughts of death, thoughts of suicide, and nicely correlate with the diagnostic criteria of the ICD-10, which has been for the depressive episodes. And mood, that is the prevailing emotional state over a longer period of a time, and mood which has been varying with the events as well. If patient is having the we have to coming if patient is having the welcome events which has been presenting in the mood swing, so it's a favorable sign as a homeopath. So abnormal thoughts, that is preoccupied with certain thoughts, obsession with some thoughts, then delusion and differentiation with the hallucination, and how to assess and how to tackle the case as a homeopath. We have to go for the psychiatric history and mental state examination, physical examination, relevant information which is needed. Then divided with the acute, subacute, and chronic state, less than 6 months, that is acute stage, 6 to 24 months, that is subacute, and more than 2 years, that is chronic. So domain of the dysfunction, that is in achievement, interpersonal and intrapersonal. So duration of the symptoms, frequency, intensity, and interviewing part, which is very essential, that is the speech, facial expression, that is omega sign, which is very important characteristic sign as a psychologist and as a homeopath. So insight, judgment, cognition, orientation, memory. So nicely correlation of the disorders with pathophysiology and manifestation. How to proceed as a homeopath, role of psychiatric. So we need the help of the psychiatric, psychologist, and we have to tackle, because 40% of the cases are, madam nicely explained that 40% of the cases are congenital. So there is role of the anti-miasmatic, then nicely correlation with the natrum mur, ignatia, and homeopathic remedy. So in nutshell, we have to properly document it for the research perspective. Whatever we treat, it should be properly justifiable, and it should be we have to understand the depressive anxiety and the depressive cases very thoroughly. So thank you very much, madam, for your wonderful knowledge and sharing the knowledge with the student and faculty of the Parul University, Faculty of Homeopathy. I invite Principal of the Parul Institute of Homeopathy and Research, respected Dr. Panda sir, to proceed with the vote of thanks. Over to Dr. Panda sir.
Thank you, Mehta sir, for nicely concluding the webinar details. I am very much thankful to today's webinar speaker, Bhuvaneshwari madam, for a nice presentation with all therapeutics, pathophysiology of depression. Now we are seeing that most of the diseases there belongs to somatopsychic. So it is the time we have to come forward and treat the diseases. I am very much thankful to the management of Parul University for giving this platform, and we are conducting the series of webinars. Now we have completed more than 25 webinars. I am very much thankful to the audience, those who are participating in this webinar, all the faculty members, all the fraternity, and I expect such type of cooperation in future also, madam. And regarding the research, vastly she has explained everything one after another. Again, I am thankful to our digital system, Brijesh Bhai and Hitu Bhai, and all the persons, those who help directly or indirectly to make this webinar successful. Thank you, the faculty dean, all my colleagues, Dr. Hina Rawal madam, Dr. Siddharth Mehta sir, and above all our dean, Dr. Purab Desai sir. Again, with thanks to all audience, I declare the end of the webinar. Thank you very much.
Thank you so much, sir. I am very happy. Sir concluded all my points and he has noted. I am very happy for it. And thanks for this great opportunity. Thank you for Parul University. To each and everyone who has given me this opportunity.
Thank you, ma'am.
so
Thank
much.
you.
Thank you, thank you so much.
Thank you, ma'am. Okay.
Okay.
Thank you so much. We can leave the meeting now. We can leave.
Yes.
Thank you, ma'am.